Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Today, July 29th, 2025, we were speaking with Dr. Ellen Eaton, an associate professor in the Department of Medicine and Division of Infectious Diseases at the University of Alabama at Birmingham. Her patient care and research centers on the infectious consequences of substance use and mental illness. Dr. Eaton serves as director of the office-based addiction treatment clinic at the UAB 1917 clinic, where she does also HIV care, and she's also director of the NIH-funded HIV and Addiction Training, or HEAT program, as well as the UAB Addiction Infection Clinical Care and Research Training program. Today, Dr. Eaton joins us to discuss treating substance use in the inpatient setting. Ellen, welcome to the podcast.
Thank you for having me.
Well, it's great to have you, and I do want to get to the inpatient side, but first let's just kind of do a brief kind of status report on what's happening in the country, what's happening in the community regarding substance use in general.
Yeah, I think that a few recent policy changes that are important for our discussion. The first is the termination of a large CDC grant, about $140 million towards overdose prevention, known as Overdose to Action. That was canceled in the last couple of weeks. And we're already hearing from our county health officers here in Jefferson County about the impact of that in reducing overdose here in Jefferson County. We saw a 20% reduction in overdose deaths in the last year in our state and close to 40% reduction in Jefferson County. Without those funds, we're expecting to see more overdoses, which will lead to more inpatient care, unfortunately, more fatalities as well. And the second big change was
before you go to the second, what exactly did that $140 million do? I mean, obviously it's around the country, but precisely did it fund Narcan? What did it do exactly?
A lot of naloxone here in our county, a lot of harm reduction counseling. I believe even fentanyl test strips were allowable with that funding. So a lot of community outreach, disseminating a lot of naloxone that went to EMS providers, community partners. We've even been able to use some of that funding for our research participants who are not insured, who don't have a way to pay for naloxone. We've been able to access naloxone for people who inject drugs that touch the UAB health system and community touch points with that money. So a big loss.
So there won't be free naloxone like we had. Yeah. Okay. And the other thing?
The other just came down last week. Many of us are trying to keep up with the news cycle. I almost missed it, except for some great communication from IDSA, HIV-MA, but this was an executive order around the unhoused population that they are now going to be required to be in either a mental health or substance use facility to, quote, restore public order. This is obviously not evidence-based and goes against the housing first model of care that many of us know from our work in HIV, mental health, substance use services. We cannot force anyone into any kind of treatment or institutional setting and expect to see improved health outcomes. So a lot of us who do this work, who care for patients who are unhoused, are very concerned that this will affect access to HIV meds, Hep C treatment, substance use services, harm reduction, especially in places like Alabama. I don't know where we will house these individuals, but I do have concerns that it will not be evidence-based in terms of provision of public health services.
Yeah. And I think because so much oxygen is taken out of the airwaves, if you will, on news cycles, we're hearing a lot about Jeffrey Epstein and God knows what, but we don't hear about this. So I'm glad you brought that up. Let's segue then to a couple other questions I had. There was something that you sent around about 2 or 3 weeks ago to all the providers at our clinic about a bad batch. I can imagine what that is, but what exactly is that?
Yeah, this was 2 weeks ago. We got a message. Those of us who do substance use work in the UAB community and in Jefferson County from some of our community partners that one of our harm reductionists in the community had heard from three loved ones that their loved one was in the hospital, intubated, had had a near fatal overdose for three individuals in Jefferson County, and three were deceased, including a few that had frequent touch points with our providers. One of whom I believe is still unidentified, unhoused. They knew where this individual lived and where he overdosed and died. So a total of 6 very serious events within a short period of time, early July. And we don't have a great mechanism in Jefferson County to disseminate that information. So that was really a grassroots effort, letting people know. But it was really interesting for me, not just because we're now seeing overdose funds being restricted, but because NPR had just done a piece that morning from the East Coast talking about a bad fentanyl batch that had led to some very serious overdoses. We're told that this bad batch in Birmingham was thought to be methamphetamine. We don't know what caused these adverse events. We know that they did not respond to traditional naloxone like they expected them to in the community. So just a really important reminder that there is a fluid drug supply. Many of us do not have resources in our community for tracking in real time to understand what it is. We're seeing different substances, maybe fentanyl on the East Coast that's contaminated, maybe methamphetamines in Alabama. Just really a call to educate all of our patients. I sent an email around to our division, to our partners. Make sure you're talking to your patients who use drugs, who care for people who use drugs. We're also working to get naloxone fentanyl test strips to our research participants, because that's another opportunity, another touch point, right, to educate them on what is going on in the community. But I do think it is very concerning in light of these other policy changes that we mentioned.
Yeah, it feels like we almost need equivalent of, at least for that population of people, some sort of bad batch or like an Amber Alert to say, hey, watch out. But it's hard to do that because it kind of outs them, and that probably won't go over very well. And you mentioned that a couple of those people got admitted. So that's what our topic is today. People who are using substances and then get admitted to the hospital for acute care. Can you kind of give us some broad strokes of what types of, I mean, I think a lot of us can imagine, but what are the most common features of admission do you see as the reason why people end up getting admitted?
Yeah, I actually have the benefit of being a part of a study where we are querying the EMR every 24 hours to see, what types of participants with substance use are touching our emergency department and our inpatient wards. It's a lot of accidents, motor vehicle, falls, seizures, the things that you would imagine with people who are using substances, and or unhoused, domestic violence, physical altercations, that type of event. A smaller percentage are coming in just for an overdose. As I mentioned, there can be sudden increases in that trend, like we saw early in July. But we do have, at any given time, patients who are just here for their overdose event. We do also have 10 to 15% of those who are admitted with active substance use have some sort of infection. We're seeing those skin and soft tissue, bone and joint, endocarditis, pneumonias, wounds, a lot of wounds, chronic wounds. That was a trend that we were seeing more 6 to 12 months ago, these xylazine related wounds, large necrotic wounds where our patients would need a lot of topical care, maybe antibiotics, maybe plastics involvement if it was thought to be a non-healing. Many times, exposed bone, joint, ligament, etc., that was going to lead to surgical intervention. So that's a smaller percentage. And I will say that trend has decreased, at least in Jefferson County. We're not seeing as many as those as we were 12 months ago.
So the xylazine, a lot of us hear about that. Are there ways to test for that in the urine drug screen?
So in Alabama, we are late adopters to many things. We have criminalized any kind of testing strip. with the exception of the fentanyl test strip. So we do not have legal means to test for xylazine in supply. Other parts of the country, not so much.
Even in a hospital, can you test the urine like with a urine drug screen?
We are not routinely testing at UAB. I imagine that some of our audience may be and may have more robust testing and diagnostic capacity. But I will just say, I mean, that's one of the challenges with this epidemic is that the contaminants and what is being used in the drug supply is really fluid, really fluid. And it's almost like by the time something has declared itself in your patients, you're seeing a clinical outcome like a wound. It's almost too late to be testing the supply, right? We're always behind.
Yeah. So what I'd like to do is I want to get to the treatment of acute withdrawal in the hospital, which is kind of a sort of a common final pathway for most any reason for admission if somebody's addicted to different, especially opioids. But let's back up to infections. So you mentioned infective endocarditis, you mentioned wounds. The xylazine can actually contribute to those wounds. Is that through skin popping or is that through IV drug use?
My understanding, and this is, although this has been in the supply for probably 4 to 5 years, we're still learning about xylazine related wounds. My understanding is that you can see cutaneous manifestations even if you are not injecting, and even if you're injecting somewhere far from the area you
Okay.
developed the wound.
So if it gets in the system and then deposits in the skin and causes a vasculitis or some sort of vascular blocking that I guess leads to the ulcer. So you've got the folks, we know how to treat wounds, we know how to treat cellulitis, we know how to treat phlebitis, and we know how to treat most cases of endocarditis, which often is right-sided and it's common bacteria that might be on the skin or maybe in the preparation of an IV dose of something with using tap water perhaps. But once they're there, let's just take endocarditis or any other situation where we need prolonged antimicrobial therapy. For everybody else, I guess, who doesn't, we don't suspect has substance use disorder, we send them home kind of early with the PICC line and they take care of that at home. What are the issues about deciding on when it's, quote, safe or appropriate to use a PICC line or for that matter, inappropriate?
Yeah. So this is a great discussion that several people, including Keena Thakrar, who's at Maine Medical, is doing some research to understand the best way to offer these options to our patients who use drugs, including those who are not in recovery. We know we're going to see some patients who are not ready to stop using. And what the literature shows is that actually people who use drugs who receive a PICC line are very unlikely to tamper with it. They actually, in qualitative interviews, will say that they're also concerned about damaging the PICC line, leading to an infection in the line, having an overdose because they, somehow got more of the fentanyl or what have you than they expected through this PICC line that they would have through their own self-injection. So the literature suggests that they actually, even if sent out with a PICC line, are unlikely to tamper with it. The literature also shows that sending them out sooner with a PICC line compared to keeping them in the hospital with our lines actually is associated with less bacteremias. And that makes sense because the folks that we keep here for prolonged admissions have multiple lab draws and multiple IV access portals of entry. They end up with bacteremia, fungi, et cetera. So you could make the argument that just getting them out of the hospital in a timely manner, including with the PICC line, may be the best choice for some individuals. I do want to bring up, Mike, that we are in a very dynamic funding climate. I worry about a lot of our Medicaid patients that may have had the option for a PICC line in a skilled facility. I worry about how these changes in the payer mix and the community options. If your plan is to send someone out only because that FQHC has availability tomorrow, well, what if that FQHC is restricting their services? What if that nonprofit has had to scale back? I do think a lot of the devil is in the detail that scenario is going to apply more than ever for these patients because a lot of the safety nets in the community are changing. A lot of what is covered by their insurance is going to be changing. So I really think this shared discussion with the patient, and that's where I mentioned Dr. Thackerar's work, because she's actually testing these decision aids, which we've seen with cancer, we've seen them with diabetes, hypertension, but thinking about substance use as a chronic disease, having a shared decision making tool, having a discussion, we can educate our patients. They actually, we have a lot of stigma towards people who use drugs, but they can't understand this. They can have a discussion. They can appreciate risk benefits. They have agency over their health. And I do think that's the most promising research, is research looking at how to have a shared discussion with our patients and walk them through the options in light of what I just mentioned, changes in community access, insurance, et cetera, and have them help select what is best for them.
Yeah, I agree. And I still do general medicine inpatient, believe it or not. And we have several people who come in with infection, and I lean towards sending them out with a PICC line. It's all individualized, like you said, but I haven't had that much in terms of negative outcomes that I've witnessed. So I think the literature, I think, is hitting on to something. Just so I think we all need to keep our mind open about it. Let's transition to the situation where you've got a patient who got admitted for some reason other than withdrawal, and they walk in with a car accident, or they've had some they've gotten into a fight, or they were abused and by interpersonal violence or something. They get admitted to the hospital, and then day 2, day 3, if they have an opioid use disorder, they will start to withdraw. What do you do? What's your approach to preventing that? And do you just your general approach to this?
This is challenging. I'm just going to acknowledge that. I want to make sure the audience knows that this is one of the hardest parts of the therapeutic environment that we are trying to create in the hospital, to retain our patients, to keep them from leaving prematurely before their antibiotics are set up, before they've been started on Suboxone, et cetera. When they're in withdrawal from opioid use disorder, that's actually the ideal time to start a buprenorphine product. And we here have the benefit of an engaged emergency department. A lot of our emergency medicine physicians have training in buprenorphine initiation. They work to get all their residents comfortable with that. But really, before they even call ID or addiction medicine, is the time to start them on that buprenorphine. When they're in withdrawal, it's a great time. They will feel better. You're giving them an opioid agonist. It's going to curb their cravings and their withdrawal. And it's going to make them feel more comfortable, so that when you go in there poking and prodding, asking to examine their wound, listen to their heart, etc., they're going to be more comfortable. And it's just going to set the stage for a much more therapeutic environment, alliance. It's going to allow you to build rapport with your patient. Unfortunately, I don't see that always happening. It is very common for me to get called as the ID doc to see someone who's been in our system for 18 hours, for example, and has been uncomfortable for 18 hours. And by the time I enter the room, I'm the first one they tell, I'm out of here, doc, right? Because someone has denied them pain medication and or addiction treatment, such as buprenorphine, and they've had it. Then you're really behind the 8 ball, right? Because even if you are the one to order the buprenorphine, the nurse has to get it from the PICC. You've got all these steps. So really, when they're in withdrawal, the main takeaway is that is the time to start buprenorphine. It is one of 3 evidence-based treatments for opioid use disorder, the other 2 being methadone and naloxone that we recommend. Buprenorphine is easy, sublingual, although there are other formulations, but in the hospital, the sublingual is what is the easiest to access. Your patient should be feeling better on the order of minutes, very well tolerated, very few drug-drug interactions. And I'll be honest, just to make this more comfortable for our ID docs, a lot of my patients have experience with buprenorphine. When I first started prescribing, I was really intimidated. Am I going to get the dose right? A lot of our patients with several years of opioid use disorder know buprenorphine. They actually know how to start it. They may have started it from a friend, something they purchased on the street. And so I just encourage you to take that on as part of your practice. If I can do it, you can do it.
And this is a sort of major change from what I remember. Even 5 years ago, guidelines were saying don't start buprenorphine while somebody's in fluid withdrawal. you got to wait and get them out of it with methadone or some other approach. And that's not true anymore. And I think you've made that very clear, and that's an important intervention. I really like what you said about getting on that early. Um, One of the things that when we've had problems with some people who got admitted and maybe they didn't get uh, treated as quickly for their pain or their withdrawal, they will disappear from their hospital room, end up somewhere outside the hospital meeting a friend who gives them something to shoot or something to take outside the hospital, and they come back in. Is that something that you're still seeing? Is there suggestions on how to manage that?
Yeah, Rachel Lee and I actually published on this at UAB Hospital, I want to say around 2018 data, and things have gotten better. We have fewer patients who are waiting in distress for buprenorphine, for example. I think more providers are comfortable starting it. We've gotten rid of the X waiver, so hopefully more physicians are encouraged that they can start this medication. And I have heard about fewer of those events, which can be really high risk when your patient goes. I mean, as you know, there are reports of patients who died at the bus stop outside of the hospital, that type of scenario.
Right, right.
I think it's less common, still a risk factor, still something we should be aware of. And it's a good reminder, Mike, that we should make sure that there is naloxone at the bedside, know where it is at the nursing station. Ideally, it should be at the bedside for our patients. And our residents and fellows should carry naloxone. It is not uncommon for a code to be called for one of our own to be the first one there, and it turns out the code is an overdose on or around hospital property. So that was a great reminder. Thank you for encouraging me to state it out loud that these events do happen on hospital property and we need to be prepared.
So let's wrap up with um, the ideal. If you were sort of in charge of all hospitals and said, especially those that have a fair amount of excuse me, admissions for substance use disorder overdoses, but also these other things that can lead to withdrawal, what's the ideal situation? What's the ideal response approach for all of us to use in addressing this substance use disorder issue in the hospital setting?
We have the benefit right now on my team of having a nurse practitioner and a peer navigator who are game changers for this population.
So you have an individual team. It's not
We have an
sort of ad
individual
hoc.
team. Yes.
Okay.
And it is supported through a grant that is ongoing the CTN study 0121, which is looking at hospitalized patients who inject drugs with bacterial complications. That research study is really focused on the hospital to community touch point. But because we have these assets, we're also seeing the benefit they have in talking to patients and developing a therapeutic alliance when they're in the hospital. And these our nurse practitioner and our peer, because they use person first language, they're not using stigmatizing language. They are um, working to make sure the patient gets their treatment for their cravings and withdrawal as a priority. They are working to link them to things like hepatitis C cure. They have just been able to develop a relationship with this population such that these patients follow up with us when they are discharged. They call us back, they come to their follow up appointments. And I think it speaks to the power, very similar to the HIV epidemic, of having peers, navigators, nurse champions who are using very respectful language. They are focused on a healing environment. They are not treating this population like they are a moral failure, deserve the health outcomes that they're experiencing. And we've had just tremendous success in engaging them in their care, getting them follow up, getting them to complete their antibiotics, as I mentioned, linking them to Hep C cure. So if I could create a protocol that was sustainable for our health system, specifically the acute care setting, but also tremendous value in that linkage to the community care, it would include a nurse champion and a peer, someone with lived experience.
I'm trying to understand the research question because it seems so darn obvious that having extra people, a nurse practitioner, a peer navigator, round individually on all the patients out of our 1,000+ bed hospital who have substance use disorders, that's got to be a good thing. And it was the research just to quantify how much improvement there is so that you can turn back around later and say, this is not only what you can do to improve patient outcomes, here's how it can save money to the hospital and to the system to prevent a readmission, um, to reduce overall costs so that they can justify the costs, which, relatively speaking, a nurse practitioner and a peer navigator isn't that expensive relative to constant readmissions and a revolving door in the emergency room. What is the research question there?
Yeah, so you got it. Looking at these types of staff, but it's also integrating that addiction and infectious diseases clinical care. Traditionally, a lot of hospitals, especially those that aren't academic, they may not even have an addiction consult service. You have your traditional ID doc who comes in, checks on the endocarditis, looks at the wound, makes sure the bank is running, and checks out. And I think what this specific study is really has appreciated, and I think where a lot of the field is going, is that without treating that underlying substance use disorder, you can treat this endocarditis, but you're not treating the whole patient. You're certainly not preventing all the other infectious complications they're at risk for, and you're not addressing the root cause, the substance use disorder. So we're looking at linkage to addiction care as well, in addition to ID outcomes. But I agree, very common sense for sure.
So you might advocate linking it to an ID consult team or maybe an independent substance use disorder team that supports, whether they have an infection or not, supports that transition, the inpatient care, but also transition to outpatient care.
Yeah, exactly.
Okay.
And we're ID docs, so we appreciate that intersection. But this same model really, I think, makes sense for anyone who's in the inpatient setting, whether they need antibiotics or not. Integrating that medical indication for admission. Was it a stroke? Was it a seizure? Was it a motor vehicle accident? Integrating addiction care, because we know so many of these acute medical issues, the underlying issue is the substance use, right?
Yep. So we're really almost out of time. I just want to give you a chance just to look into the future. Where do you see us in 5 to 10 years with this? And I'd say look at it with an optimistic eye, that if everything goes the way it should, where will we be in, let's say, 10 years? There still will be substance use disorders and people getting admitted. What would you like to see?
Yeah, I would like to see expansion of harm reduction. We were on a good path to expanding harm reduction, but in the last few months, we're starting to see restrictions on grants like SAMHSA grants, where they're no longer interested in funding harm reduction. I would like to see states take that on. I would like to see counties like Jefferson County offer syringe service programs integrating substance use, buprenorphine clinics where they treat Hep C, for example. I would like to see that kind of status neutral approach to substance use, right? Whether it's HIV, Hep C, treating the underlying substance use in low barrier models. I think integrating is becoming more and more common. We're seeing more docs like myself, who's an ID doc, taking on addiction. We need to see that in the nursing field. We need to see that in a lot of the physician extenders as well, especially in rural areas. We are not recruiting ID docs or addiction medicine physicians to places like Dothan, Alabama, Selma, Alabama. We need our nursing schools and other professional schools to take on that integration. And then lastly, I think street medicine is really an area that many of us are growing into. I mentioned the executive order that's going to really restrict our unhoused population, but I'm also hearing about really innovative street medicine projects like in Montgomery, Alabama, funded by the city of Montgomery, doing street psychiatry. And we're going to go down there and work with that team next month and get one of their clients on PrEP. So that's a great example. Street psychiatry, PrEP, Montgomery, Alabama. I'd like to see more and more of that.
Well, I would too. And we are out of time. I just want to thank you for a really comprehensive review of a very, very common challenge in the hospital setting. And I think you've given us a lot of concrete advice on how to approach this. And I'm with you. I hope we do expand our reach beyond just these hospital systems that might have a research program, but going out into rural areas where a lot of the substance use disorder populations are nested. Think of Scott County, Indiana. Years ago, it was HIV, but they're mostly hepatitis C is a common co-conspirator, if you will, with IV drug use. Hepatitis B, you can get vaccinations done, all kinds of things. So a lot to do, but I think you've given us a great roadmap. Thank you so much for doing that and for being with us today.
Thank you. It's my pleasure.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed on this podcast do not necessarily reflect the opinions of the IAS-USA and its affiliates. And the viewpoints of the individuals on this podcast do not necessarily represent the viewpoints of their institutions. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode. Thanks for listening.